As outlined, we are going to see components of short-term hormonal contraception. Depot-medroxyprogesterone acetate is number 1. Number 2 is combination oral contraceptives. Number 3 is progestin-only oral contraceptives. Number 4, combined contraceptive patch and vaginal ring. As objectives of our topic, we described short-term hormonal contraceptives. We will explain mechanism of action. We identify advantages and disadvantages of short-term hormonal contraceptives. Then we will describe non-contraceptive benefits. We start with the case study. We have a 23-year-old nulliparous woman named X. Recently got married. This lady does not want to get pregnant in the next 6 months. What short-term hormonal contraceptives methods do you counsel her to use? So we are going to see number 1 of short-term hormonal contraceptive, depot-medroxyprogesterone acetate. This is a suspension of microcrystals of a synthetic progesterone which is injected intramuscularly, IM. It gets its active level within 24 hours after injection. The serum concentration is 1 nanogram per milliliter, which is maintained over 3 months. The single dose of 150 milligrams suppresses ovulation in the most women for as long as 14 weeks. The regimen consists of 1 dose every 3 months. New depot is being done nowadays as a lower dose of 104 milligrams versus the previous one, which is 150 milligrams. Here you can see the illustration showing how this injection look like. This the flacon, the ampoule of the Depot-Provera, which contains 150 milligram per deciliter. How does Depot works? What is the mechanism of action? Mainly the law is to suppress the ovulation from the pituitary gland, and it works on reducing the sperm transport on the upper genital tract in the fallopian tube. Actually, they reduce the motility of the tubes. The other role is to change endometrium, making the implantation to less likely be. So to change the endometrium lining, then the implantation is not done. And again, it thickens the cervical mucus. So this prevents the sperm penetration to the uterus, to the upper part. The efficacy of Depot. The Depot is really extremely effective contraceptive option because within 1 year of use, the failure rate is only 0.3%. And the weight and the use of concurrent medication does not alter the efficacy. What are the advantages of Depot? Really, there is no serious adverse effects of like the estrogen. The dysmenorrhea is improved, and Depot reduces risk of endometrial and ovarian cancer. So it is somehow protective for endometrial and ovarian cancer, and it is suitable for women who cannot take estrogen products. It is also safe breastfeeding mothers. It has some disadvantage. You can see that in the first year of use, some women, around 50%, are amenorrheic. Some women may experience persisting irregular bleeding. They may have spotting. Another disadvantage of Depot is that it can delay fertility. Only 70% of women who have stopped using Depot, only 70% of them may conceive within 12 months, and only 90% do within 24 months. Another disadvantage of it can, for some people, cause osteoporosis if it is used longer. But when you stop depot, the osteoporosis is improved. It doesn't continue. And because it's given every 12 and 14 weeks, you can see also it is one of the disadvantages to come every 12 and 14 weeks for administration. Number 2, we are going to see oral combined pills, commonly called OCPs. These pills contain low dose of progestin and estrogen. The estrogen which is there is called ethinyl estradiol, which is used in oral preparation containing about 35 micrograms. But recently, low dose of ethinyl estradiol 20 micrograms is available. Lower doses are associated with a decrease in the incidence of estrogen-related adverse effects. This OCPs contains also progestin. The most common is levonorgestrel. OCPs can be monophasic or a phasic combination. Among monophasic, those are OCPs with constant dose of both estrogen and progestin in each of the active pills. For phasic combination, they can alter either on one or both hormonal components. And most of the formulation have 24 hormonal active pills, which are followed by 7 placebo pills. Actually, the mechanism of action of OCPs is like the other short-term hormonal contraceptive. They suppress the ovulation, they reduce the motility of the tubes, and they change the endometrium, making implantation less likely. And they thicken cervical mucus, and this prevents sperm penetration. When can a woman start OCPs? A woman can start OCPs during the first day of menstruation cycle. She can take them when she wants to switch from another methods. And after abortion, OCPs are safe to be used. So what will happen if you missed one pill, one pill or 2 pills? So when you miss 1 or 2 pills, as soon as you remember, you have to take what you have missed. But if you have missed more than 2 consecutive pills, then you have to use a backup method. What is the efficacy of OCPs? The effectiveness depends on the user. The failure rate ranges from 0.1% with perfect user to 8% with typical user. Health benefits of OCPs. The OCPs are used to treat irregularity of menstruation. Those women having menstrual irregularities, they can use them to make it regular. They reduce those mid-cycle pain after ovulation. Also, they improve iron deficiency anemia. They improve also dysmenorrhea. And they improve severe premenstrual symptoms. And OCPs may help to manipulate the cycle when you want to avoid menses during certain events. For example, if you don't want to have menstruation during the coming 2 months, you can take OCPs and you jump those pills, those placebo. In between, you will not have menstruation. Yeah, they prevent benign conditions such as benign breast disease, PID, pelvic inflammatory disease, and functional cyst. And as well, ectopic pregnancies are prevented. And they prevent epithelial, ovarian, and endometrial carcinoma. They have also some disadvantage. They don't provide the protection for sexual transmitted disease because it is daily administered. You can see that this is also a disadvantage. And its consistent use may increase the failure rate. As some more adverse effects, they can cause nausea, breast tenderness, amenorrhea and headaches, venous thrombosis, hypertension, atherosclerosis and stroke, hepatocellular carcinoma. Breast cancer is controversial, as well as cervical cancer. Also, this is controversial. What are contraindications to OCPs? Women having cerebrovascular disease or coronary arteries may not take this. Someone having a history of DVT, deep venous thrombosis, pulmonary embolism, or congestive heart failure, those are not allowed to take OCPs. Untreated hypertension, diabetes with vascular complication, undiagnosed abnormal vaginal bleeding, active liver disease, and the women who are older than 35 years and who are heavy smoker of cigarettes are not allowed to take OCPs. Those are really contraindication, absolute one to take OCPs. We are going to discuss on progestin-only oral contraceptive, which are also known as mini pills. They are indicated for women who are breastfeeding, for women who have contraindication to estrogen use. And we have two formulations with lower dose of progestin than OCPs. One formulation contains 75 micrograms of norgestrel, and the other one has 350 micrograms of norethindrone. What is the mechanism of action? It's, as I said, the mechanism of action is the same for all short hormonal or contraceptive. They suppress ovulation, they increase the viscosity of cervical mucus, and they make the endometrium to become atrophic. Then they reduce the motility of the fallopian tube. This is the illustration showing that. What is their efficacy? Actually, the failure rate of them is, for typical use, is 80% in the first year, and it increases with inconsistent use. The advantage is that there is no evidence of serious complication like thromboembolism. No contraceptive benefits include the decreased dysmenorrhea, menstrual blood loss, and the premenstrual symptoms. And they are not like the PO, which really delay the fertility. For this one, once you stop them, fertility is immediately established after you stop them. The disadvantage, they can cause unscheduled bleeding and spotting, and they need really compliance with usage. And they have some also adverse effects like nausea, breast tenderness, headaches, and amenorrhea. So number 3, we are going to see combination patch contraceptive. They are not common here, but we are going to have a look on them. Those are transdermal patch, which release estrogen and progesterone directly into the skin. They release a sustained low their dose of steroids equivalent to the lowest dose of oral contraceptive. They have greater compliance and decrease adverse effects, but they are less effective for women who weigh more than 90 kg. So as you have finished to see those short-term hormonal contraceptive, you come back on our case study and see what could be the answer. So it was a 23-year-old nulliparous woman named Alice, or X, who is recently got married, but she doesn't not want to get pregnant in the next 6 months. So what short-term hormonal contraceptive method do you consider? So what is the answer? Every woman has to be considered on every method, but for this particular woman, we need to warn her on delay on fertility if she decides to use DEPO. So as summary, we have seen short-term hormonal contraceptive, which primarily acts through inhibiting ovulation. This is the mechanism of action, which is the number one. We have seen that the PO is most common short-term hormonal method and is known for delaying return of fertility. OCPs with low dose estrogen are safe and have to be taken consistently. And progestin-only pills is preferred for lactating women. Thank you.